Good afternoon.
Good afternoon, sir.
Good afternoon, sir.
Good afternoon, sir.
Good afternoon. How are you doing?
Yeah, good by God's grace. You.
We are
Thank God.
We
good.
are good.
Yourself?
We are
Thank
good
God.
by
Thank God. I'm fine. Happy Valentine's Day to you all.
MTU,
same
sir.
to you,
Same
sir.
to
Happy
you,
Same to
sir.
you, sir.
So,
So I hope you
so this,
brought a chocolate.
so the Valentine chocolate for you this afternoon through the lectures.
Same to you.
Yes.
Thank
Mute
you.
yourself.
Yes. Where did we reach last time? Check where did we finish the mental disorders? Did we finish with them? The musculoskeletal disorders. Please, I need a feedback. Where did we get to? Class rep. Edward. Well, Edward is not here. Osteomalacia, which means that if we go to osteomalacia, it means we finish with the musculoskeletal system, because that is the end of the musculoskeletal system. So we are going to start with the nervous system condition. Nervous system condition. Please, last week we finished, somebody said rheumatoid arthritis, but we finished with rheumatoid arthritis. And we moved to osteomalacia, right? So we discussed osteomalacia, or we didn't discuss osteomalacia at all. Did we discuss osteomalacia? Okay, so we are going to consider Parkinson's disease and Huntington's disease. Then we look at Alzheimer's disease and multiple sclerosis. Yes, Alberta. Yes, Alberta. Your microphone is muted. Alberta Boatima. Alberta Boatima Ayakwa. Your microphone is opened. Is there anything you want to say, or you are just refusing to mute it? Alberta, or she is not with the phone. Today you have started too early. Mute your microphone. Okay, so we have Parkinson's disease. Parkinson's disease. This disease is just the distraction of the brain nerves called the cerebral neurons. So when the neurons get destroyed, it affects the entire body in terms of the functions of the nerves, movement, alertness, memory, speech, all becomes affected. The nerves get degenerated and they are destroyed as you age. So the condition is more or less restricted to age, aging-related condition. As you age, the cerebral nerves, especially the neurons, they're supposed to transmit impulses for functional abilities. Once the nerves are destroyed, the functions are impaired. So with the definition, we are saying that it's a slowly progressing neurological movement. If you can't hear me, please let me know. If my voice is fading, let me know. So the condition starts on a slow pace and progresses steadily as you age. Then eventually, it becomes worse. When it becomes worse, that is where there is a disability. Then you can't do anything unless you need a support from the extended family or from the close family. Slowly progressive neurological movement disorder. So the disease actually affects movement. There's a problem with locomotion, movement. And then eventually the movement becomes, the patient becomes and don't move anywhere. Has to use a wheelchair to take the patient around. Age is a risk factor for this particular condition. The young adults do not normally experience the disease. The condition normally starts from middle age and progresses during the late life, somewhere 60 years and above. So the risk increases with age. It will be very rare for young ones to develop this particular condition. Apart from age, where the condition becomes so common, from 60 years and above, the next risk factor is hereditary. Hereditary. Having a close relative who has developed Parkinson's disease increases the chance of you getting the disease. And the percentage is, if you have both families developing the condition, you have 100% chance of developing the condition. If you have one parent developing the condition, you have 50% chance of developing the condition. If your uncle develops the condition, you have 25% chance of developing the. So it depends upon how close the relative is to you. That increases your chance of getting the condition. So that is Parkinson's disease. From hereditary, we look at sex in terms of gender. And with gender, the men are more prone, more likely to develop Parkinson's disease than their women counterpart. Men are more likely to develop Parkinson's disease than their women counterpart. And people who are exposed to toxins based upon their working, where they stay, where they work, so any toxin that you exposed to. For example, farmers are exposed to herbicides and pesticides. I was walking around, I got to a filling station where they were filling gases, butane gas. And the guys, all of them were not wearing masks. And they were inhaling the butane gas. I gave them masks, they said they will use it. So for a long term, these people may become victims of this condition. Our farmers who go to farms, they spray with herbicides and pesticides. They do not put on masks and they inhale, especially when the wind is against them. The wind blows the pesticides and they inhale them. These are toxins that is affecting their lungs. And very soon, they will start experiencing these conditions. So pesticides slightly may increase your risk of Parkinson's disease as well as herbicides and other toxins. So in Parkinson's disease, the nerve cells in the brain gradually breaks down. So the symptoms comes as a result of loss of neurons, loss of nerves. And these nerves, they produce what is called chemical messengers. So when they are lost or degenerated and they get disappeared, it means you are going to lack a particular chemical messenger responsible for specific functions. The specific chemical messenger here in the brain is called the dopamine. So people with Parkinson's disease have a very limited amount of dopamine or nil at all, depending on the number of nerve cells in the brain. These nerve cells are responsible for producing this dopamine. When the dopamine level decreases, then there's abnormal brain activity, and it leads to impairment in brain function. It is the combination of dopamine and acetylcholine that gives you a fine, precise movement. So those ladies who are very good at catwalk, they walk, they swing their legs and they swing their waist, but they will not fall. It means they have a very good balance between dopamine and acetylcholine. When you grow and you have a problem with the brain degenerates, gets the corpus stratum destroyed, the basal ganglia, they get degenerated. Then the nerve cell around this corpus stratum becomes degenerated, and therefore dopamine levels falls down drastically. and movement becomes a problem. These are all risk factors that can affect the nerves. The exact cause of Parkinson's disease is unknown, and that makes management difficult and prevention difficult. If, like cancer cells, if you know what really brings about cancer, then we can prevent cancer. But as we speak, we only know the predisposing, the risk factors of cancer. We don't really know the exact cause of cancer. And that is what you have with Parkinson's disease. We don't really know what brings about Parkinson's disease. What causes it? We don't know. All that we know is that there are risk factors that affect, which age is one of them, that affect the brain functions, thereby depleting the brain nerves and causing a reduction in dopamine levels, affecting movement, bringing about impaired movement and movement disorders. The disease is associated with decreased levels of dopamine and due to destruction of pigmented neural cells. And these neural cells are found within the substantia nigra, within the basal ganglia of the brain. So the basal ganglia contain the substantia nigra, and these areas are the areas that contain the pigmented neural cells, the cells responsible for producing dopamine. It is contained within the substantia nigra. When this area is affected by degenerative changes, you lose the nerves. And once the nerves are lost, definitely dopamine levels drop down. The nuclei of the substantia nigra projects fibers or neural pathways to the corpus striatum, where neurotransmitters are key to control complex body movement. So the nerves that move from the substantia nigra passes through the corpus striatum, and that is where the dopamine levels are kept. And these functions to bring about fine, precise movement. When their levels fall low, there's problem or disordered or impaired movement. So through the neurotransmitters, we have acetylcholine, which brings about excitatory movement, and we have dopamine, which brings about inhibitory movement. So it is the balance between acetylcholine and dopamine that gives you a fine, precise movement. In other words, you shouldn't have too much acetylcholine to give you rapid movement. You shouldn't have too slow dopamine to give you slow movement. Excuse me, give me 2 minutes. I'll be with you very soon. Okay, so sorry for the interruption. Let's move on. So
Hello, sir. Hello, sir. No.
yes.
Sir, please, you are muted.
Okay, so the loss of dopamine stores in this area as a result of degeneration of the nerves results in the brain. So once you lose the dopamine, because the nerves get degenerated, it means that dopamine levels will go down and acetylcholine will increase. And once acetylcholine increases, they bring about the excitatory movement. So it means that dopamine levels reduces, you have more excitatory neurotransmitters. That leads to an imbalance between balancing the movement of fine, precise, and increasing in voluntary movement. So here there's an increase in voluntary movement. The person moves at a faster rate than normal because you have more acetylcholine, which is excitatory. However, other conditions may also affect the synaptic junction where acetylcholine is released. And once acetylcholine is affected, acetylcholine levels go down. So you have low and slow movement. We call it bradykinesia. And even with the loss of dopamine, it can still cause some neurotransmitters not able to bring about impulse transmission. And this can also bring about bradykinesia, which is slow movement. So we have vague signs and symptoms when this affects or this condition affects the brain. So we have stages of the disease. So symptoms of Parkinson's disease are usually mild, and typically you don't really show any signs and symptoms, and they occur slowly. They do not interfere with your daily activities at all. You do all your activities in a very serene manner without any difficulty. It's very difficult for you to notice that signs and symptoms are in place. They are not easy to detect because the condition is difficult to come by with various investigative equipment. We don't really get the techniques to detect them early. It may mimic other conditions as well. You may think it's something else and not Parkinson. You might think it is the normal sign of aging. There could be fatigue, general sense of uneasiness. You may feel slight tremor or have difficulty standing. Then symptoms start getting worse, where you start feeling tremors, muscle stiffness, or as a result of decreased levels of dopamine. Then movement problems, which may now affect both sides of the body. So you have problem with balancing. You have a problem with balancing. So balance problems and falls become more common. You easily fall down. You can't keep your balance. You may still be fully independent, but duty of everyday living, such as bathing and dressing, are becoming more difficult to do and take longer to complete. So when you are bathing, you take so many hours in bathing. When you are grooming or dressing up, you take so long a time to do them because you are not alert. You are not smart. The nerve there that gives you the alertness and smartness is gone. It's gone so low. So smartness, alertness, fast, or everything is gone. When the condition gets to the mild late stage, standing and walking are becoming more difficult. So there's a problem with standing and walking. There's a problem with standing and walking. Sometimes you may require assistance with a walker or walking device, crutches, canes, for you to move about. Sometimes you have to employ a full-time nurse at home to help you. That is where the nurses who travel to Europe, they go and do. Because in Europe, the patients there, they live longer, they advance in age, and these conditions are common there. So they have problems with Parkinson and other age-related conditions. So the nurses are employed at home and they pay them at the end of the month. This is okay. Somebody gets two nursing home patients and they are okay. The salary at the end of the month is more than enough. You help them, you bath them, you feed them, you clean them, you dress them, you play with them, you medicate them. And that is what you do for them. Because they don't have anybody to care for them. And not all of them would like to join the nursing homes where you have plenty of patients. Some would like to be nursed in their own home environment. And then the children will say, we will take care of them, the cost, we pay you. You run labs, you take blood samples and run labs and see. Then in the advanced stage of the condition, the patient may require a wheelchair to move about or even become bedridden. The patient sometimes may experience hallucinations and sometimes delusions, and where they will need a full-time nursing care at home. The signs and symptoms here, we have tremors, slowed movement called bradykinesia, rigid muscles, or as a result of a fall on the dopamine levels, impaired posture and balance, brings about easy falls on the ground, loss of automatic movement. You can't initiate quick, fast movement because of the reduced neurotransmitter dopamine. Speech becomes a problem. So your voice changes. Writing chest, there's a sign that you show called writing chest. When you are moving, it's like you are using your chest to write. So you move your chest as if you are writing with your chest. That is what the disease normally signifies. There's depression. Ask yourself, I was able to do ABC. Now, somebody does everything for me, including sexual activities. You get the person depressed. And you need somebody to bring and raise the mood. A professional to talk to you, to reassure you that there's hope. Then there's permanent brain changes, so degeneration of the brain. There's disturbance, sleep disturbance. In the night, you can't sleep. Everybody is asleep. So that is the depression. Could be exogenous depression or endogenous depression. Decreases facial expression as a result of poor nervous innervation. Chewing becomes a problem, and even swallowing reflexes are gone. So problem with swallowing hard food. The food must be soft. And sometimes there's the need to even pass NG tube and feed. Because the nerves supply the bowels and then the bladder, there's problem with urinary problems. Sometimes you experience incontinence. There's loss of smell. You can't even taste food because your smell is gone. The olfactory nerve is gone. You lose interest in everything. So loss of apathy, loss of interest. There's greater apathy. You don't care about anything. You greatly lose interest. Diagnosis is sometimes difficult because early symptoms can mimic a lot of this brain or nervous disorders. We don't have a specific blood test or other labs to diagnose the disease. So imaging tests such as CT scans, MRIs may be used to rule out other disorders that cause similar symptoms, like Huntington diseases. We do history taking, medical examination, or medical history and physical examination. All is done. We normally encourage the patient to participate in exercise. You know, one of the antidotes in delaying Parkinson's disease is exercise. Exercise. Exercise sharpens the blood vessels, improves circulation to the substantia nigra, the basal ganglia, and blood supply increases. The blood brings nutrients, oxygen, and the area doesn't get degenerated. The nerves there get their nutrients and they remain healthy. And when the nerves remain healthy, it means they will continue to produce dopamine. And when dopamine levels are high, you have good movement, good balance, good speech, and you are healthy. Exercise is good to give you the fine, precise movement and balancing. The prescribed medications must be served. The patient should be well hydrated with fluids, and lack of activity, he may experience a lot of constipation, so the food should be full of roughage and fiber. Advise the patient to take time when they are eating, because they eat slowly. There's problem with chewing and swallowing. The chewing problem. Help the patient on the speech exercise to improve communication. So see a speech therapist. Because we don't know what really causes the condition, it's difficult to prevent the disease. Very, very difficult. If you know what causes it, then you can prevent it. Researchers have proven that those who take a lot of caffeine-related drinks, some people are fond of coffee, tea, cola drinks, are related to Parkinson's disease. But those who do not drink them, it will be difficult to associate Parkinson's with them. So lifestyle. And that is why the disease is more common in advanced countries, because they take a lot of coffee. If that is true, this is proven by research. So here, there's also thinking difficulty. So thoughts and thinking becomes a problem. depression and emotional changes, chewing and eating problems, sleep problems and sleep disorder, bladder problems because of the nerves that supply the bladder and then the bowels. There's constipation because the nerves do not innervate well in the abdomen. So there's poor peristalsis, and this brings about constipation. Sexual dysfunction. You don't have the urge to even have sex. The drive is even gone. Any question before we move on to Huntington's disease? Any questions so far? Any questions so far?
Hello, sir. Please, good afternoon. Please, I would like to ask, is what's the difference between the Parkinson's disease and the Alzheimer's disease? Since for both they have like slow movement, and then also it affects their it affects the you said the dopamine and the other one. Left. I know for the Alzheimer's it affects that one, but I don't know. For the difference, I'm confused now. Please, what is the difference?
Hello? Yes, I got muted, so I wasn't able to communicate to the lady who asked the question. I was muted from the host. So the lady, please, can you bring up your question again so that we look at it? Yes, can you ask your question? The question you ask, please unmute her and let her.
Hello, sir.
Yes.
Sir, please, if I heard her clearly, she was asking the difference between Parkinson disease and Alzheimer's disease, since in both of them the coordination is very slow.
But we are now going to treat those conditions.
All right.
We are not going to treat from here. We are treating Huntington's and Alzheimer's. So just keep your cool. We'll get there. Then you can see the clear difference between them. I hope it's clear.
Yes, please.
We are not going to treat Hunt. So why do you have to preempt or rush into what we are now about to treat? So you take your cool. When we finish, you will exactly know the difference. Then we will Alzheimer's. Then you can compare the three. I hope it's clear. So this condition, which is Huntington, is also a progressive brain disorder. So this also affects the brain. Likewise, the Parkinson disease affecting the brain nerves. Okay, so there are so much noise. I needed to come to where the noise will be less so I can teach. So the external noise was interfering. So this condition, Huntington, is a progressive brain disorder caused by a single defective gene on the chromosome 4. So here is talking about defective gene on chromosome 4, one of the 23 human chromosomes that carry a person's entire genetic code. So the Huntington disease is talking about a single defective gene on the chromosome 4. And Parkinson disease is talking about degenerative changes of the brain cells, the brain nerves. So once we take you through, you know the difference. They are not the same. So Parkinson disease is talking about a disorder caused by a single defective gene on chromosome 4. And this is one of the 23 human chromosomes that carry person's entire genetic code. The defective gene is dominant, meaning that anyone who inherits the defective gene, one of them, one parent will definitely develop the disease. So you don't need two because it's a defective gene. Just one parent bringing about one of them will definitely show, because even the presence of one pair will show the disease, because it is inherited as a dominant gene all the time. The defective gene holds the blueprint for a protein called Huntingtin. That is why the name was given to the Huntingtin. So the defective gene gives way for the abnormal protein called Huntingtin to develop. And this protein or this problem normally function, the protein normally function isn't yet known, but it's called Huntingtin because scientists identify its defective form as the cause of Huntington disease. So once there is a defective gene on chromosome 4, it allows the development or the appearance of Huntingtin, a protein called Huntingtin. So the disease is named Huntington disease because of the appearance or the presence of the abnormal protein, Huntingtin. So the defective Huntingtin protein leads to brain changes that cause the symptoms associated with the disease. So the bottom line here is that with Huntington disease, there is a disorder of the chromosome 4. And this disorder leads to the formation of a Huntingtin protein. And this Huntingtin protein is the cause of all the problems associated with the disease. So the appearance of the abnormal protein Huntingtin brings about the signs and symptoms manifested in the disease. So the person who asked the question, I hope you are following. This is not the same as Parkinson's disease. So you have to note them down. The cause is different. The Huntington is talking about chromosome 4 abnormalities, and therefore Huntington protein appearance. And Parkinson's disease is talking about defective and degenerative gene within the substantia nigra in the basal ganglia. So they are different. The condition is not fatal. If a person may die from this condition, it is due to associated infections like pneumonia and injuries that kill them. Otherwise, the disease will not kill you. It is how you manage it that will determine whether you die early or not. Some have lived with Huntington for so many years. Because of proper management, they are still alive. As happens in Parkinson, there's no cure. There's also no cure for Huntington disease. But treatments are available, so you can manage the symptoms very, very well. Huntington disease really develops between the ages of 30 and 50. That is the middle age to the late adults. Some, however, can appear around age 2, which is very, very rare. Very, very rare. Or some can even appear very late in one's life. That is after. So extremes of ages can still have Huntington disease, but they are not rare. The common developmental ages are from 60 and above, and sometimes from 30 going, those with genetic predisposition. The risk factors: AD is passed from parents to child through a mutation in a gene. So there's a mutation in a gene, which is chromosome 4. The chromosome 4 gets mutated, the gene can change, and they become abnormal. The gene is responsible for Huntington's disease lies on chromosome 4, a chromosome that contains all or part of the genetic material that makes up a person. So that is the chromosome 4. When a person has Huntington's disease, each child has 50% chances of inheriting the copy of chromosome 4 that carries the disease or the Huntington disease mutation. So in every pregnancy, there is 50% chance of the child copying or picking up the disease from the parents, because the disease is expressed in a dominant form. So in every pregnancy, the child has 50% chance of taking the disease from the parents. If a child does not inherit the HD mutation, he or she will not develop the disease and cannot pass it to subsequent generations. So for you to develop the disease, you need to inherit it from parents. The abnormal or the mutating gene. You need to inherit the mutating gene to pass it on to subsequent generations. If you do not inherit the gene, the abnormal gene, you cannot pass it on. People with Huntington disease have an abnormal, repetitive, greatly expanded three-letter code or triplets in the DNA sequence that is found in genes. So you have repeated code of the genes in one homologous chromosomes. Instead of 2, you may have 3 or 4, and that makes it abnormal. Repeat it. They repeat the code. The DNA uses a triplet to provide or prescribe the order and identity of amino acids, the protein building blocks. In Huntington disease, the triplet involves the excessive repeat of cytosine, adenosine, and guanine, called CAG. So this protein is repeated in the homologous chromosome. It's repeated. So as you copy the protein, the CAG is repeated. So cytosine, adenine, and guanine, they get repeated and makes it abnormal. Most people have fewer than 23 CAG repeats in Huntington disease gene and are not at risk for the disease. Less than 23 CAG, they are not at risk for the disease. Individuals with the disease may have 36 or more. So those with 36 or more CAG may have the disease. If you have 27 or less of the CAG, you will not have the disease. You will not show any signs and symptoms. You are not at risk. If you have 36 or more repeats, you have the disease. People who have repeats in the intermediate range, 27 to 35, are unlikely to develop the disease. It's not certain, but they could pass it on to future generations. For you, it will be difficult for you to express the disease, but you can pass it on just like AS genotypes. You can give it to your generations in the future. So that is how the disease is expressed itself, using the repeated proteins. Less than, fewer than 27, no signs and symptoms, no risk factors. More than 36 or more repeat of the CAG, you are likely, and you show the disease. In the range of 27 to 35, you are unlikely to develop the disease or show up, but we can pass it on to future generations. So number of CAD repeats, Less than 26, normal range, individual will not develop the disease. 27 to 35, individual will not develop the disease, but the next generation is at the risk of the disease. 35 to 39, some but not all individuals in this range will develop the disease. Next generation is also at risk. Greater than 40 individuals will develop the disease. When AD occurs without a family history, it is called sporadic Huntington's disease. If one develops the condition and there's no relation to their family history, no genetically inherited, they did not inherit it from the family, then the name given to it is called sporadic Huntington disease. So the hallmark symptoms of the disease is uncontrolled movement of the arms, legs, head, face, and upper body. So there's uncontrolled movement. As you move, you can't swing your hands well. You can't move well. The way you swing your leg and your head and your hand, everybody sees it to be abnormal. Uncontrolled movement of the arms, legs, head, face, and upper body. Upper body, you move your chest as if you are writing with your chest. You shake the body. You move your hands uncoordinated with your leg movement. Decline in thinking, reasoning skills, including memory. You just forget things so easily. You can't reason appropriately. Thinking becomes a problem. Concentration, you lose concentration easily. Judgment is poor. Everybody is saying white, but you point out to the black or red. Poor judgment. Ability to plan and organize becomes so poor, so you are disorganized. You can't plan anything proper. Alterations in mood, especially depression, anxiety, and uncharacteristic anger and irritability. You can't cope with the disease. That makes you very, very, very anxious. And you develop anger easily. You become irritable. Obsessive compulsive behavior leading to repetition of the same question or activity. So you develop obsessive compulsive. So whatever you do, you repeat it, you do it and do it and do it again. You ask question, you repeat asking the same question. The activity he has finished, you keep on doing it. Investigations here, we do neurological examination and history taking. So it is through the patient history taking that you'll be able to ask family history and genetic relations. An in-depth interview is conducted to obtain the medical history, including any family history, to rule out other conditions. Diagnostic imaging like computer tomography, scan or magnetic resonance imaging as the disease progresses. These scans are typically revealed shrinkage in part of the brain and enlarge of the ventricles of the brain. So some ventricles get enlarged with the CT scan or MRI. You get the ventricles enlarged. And some portion of the brain get degenerated. So genetic tests, the most effective and accurate method of testing for Huntington disease is called the direct genetic test. Direct genetic test. It counts the number of CAD repeats in the Huntington disease gene using the DNA taken from a blood sample. The presence of 36 or more repeats supports a diagnosis of the disease. A test results of 26 or few repeats rule out Huntington disease. So this is what's called direct genetic test. They count the number of repeats, and they can either confirm or otherwise the diagnosis. There is no treatment to stop or reverse the cause of the disease, just like the Parkinson's disease. However, medications may be prescribed to help control the medications, the emotional, and then there's other signs and symptoms. Movement problems that are associated with the disease may be controlled by medications. Thinking disabilities or thinking problems, lack of concentration, sleep disturbances, all the signs and symptoms we can use medications to control. Most of the medications available for HD symptoms work by modulating the neurotransmitters, the chemical messengers that shuttle between the neurons. Tetrabenazine, which causes depletion of the neurotransmitter dopamine, is prescribed for treating Huntington-associated involuntary movement. So the tetrabenazine can cause the depletion of dopamine, but however, it is prescribed for treating Huntington disease to control the involuntary movement. Antipsychotic drugs such as risperidone, clonazepam, haloperidol, and other drugs such as clonazepam may help to lessen the chorea, the writing movement, and may also be used to help control hallucinations, delusions, and violent outbursts. It calms them down, keeps them cool. For depression, drugs such as citalopram, fluoxetine, sertraline, nortriptyline, they are all prescribed to manage the depression. Tranquilizers can help control anxiety, and lithium may be prescribed to combat pathological excitement and severe mood swings. So these are antipsychotic medications that is given to control the signs and symptoms. Any questions so far for Huntington? The lady who was asking a question, I asked you to come up with your question so I can appreciate it well. She said, I think it was Dapa. I can't unmute. So Edward should assist her to mute so we can hear her question. I don't know if my voice is still breaking. Yes.
Hello. Sir, please, I understand now. And then for the Parkinson's, what are some of the drugs that we can give to manage the condition? So for the Parkinson's, we talked about the risperidone and the other one. Thank you.
So that improve the level of dopamine-induced medications are given. And once they are given, they restore the dopamine levels. So it more or less balances with acetylcholine to give you the precise movement that you need. So the dopamine enhancers and other antipsychotic medications to treat other psychiatric conditions like hallucinations, depressions, and other things. Ajiman, he says, I'm confused about the 36 repeat. What makes you confused? 36 or more will show the disease. That will confirm that you have the disease. So what makes you confused there? What is the confusion here? If it's less than 27, you don't have it. You can't pass it on. In the range of 37 to 35, you may not show it, but you are likely to pass it on to generations. So what makes you confused here? Yes, a patient can exhibit signs and symptoms of Parkinson at the same time Huntington disease. Yes, patients can exhibit that. Patients who are greatly deteriorated can have the two, because having one can lead you to get the other one easily. Yes. But mind you, the Huntington is genetically inherited. So if you are not genetically prone, then you don't go there. You don't go there. Genetically prone. Yes, hands up. Jima, your hands is up. And Prince. So Jima, let's hear you and Prince. Please unmute them. Edward, unmute the two so we can hear them. Prince, Kweku, Pra, and Love Jima. Edward, unmute them.
Hello, sir.
Okay,
Good afternoon.
hello, sir.
Yes.
Please, this love. Sir, please,
Yeah.
so I wanted to inquire, when you started with the Huntington, you said it's a progressive brain disorder by a single defective gene. That is the gene on the chromosome 23.
Chromosome 4. Chromosome 4.
It's 4 rather. Okay.
Chromosome
Thank
4.
you. I think
Chromosome 4 is part of the 23 chromosomes. So go ahead.
Okay. Okay. But sir, my question is answered because I heard chromosome 4 later. So I wanted to confirm. Thank you.
On the chromosome 4 is part of the 23rd chromosomes, right? Okay. Yes, Love, Jima, let's hear you.
Hello, sir. Good evening.
Good evening.
Yeah, sir, please. So I just want to be sure, when we were tackling the Parkinson disease, you made mention of that the condition itself will not kill the patient or will not cause death, but rather infections or other injuries from fall. So I just wanted to know whether this scenario applies to the HD. Thank you.
Yes. It is about how you manage the patients. If you manage the patients very well, they are not fatal. The condition is not fatal. The God patient is vegetative and it stays at one place, lack of pneumonia. So it is up to you to identify clinical features very early and make sure that they are healthy. Take blood samples for life frequently, feed them well, bath them, prevent infection, and groom them well. It is the management that you apply to determine whether they will live long or not. They're like babies at that time. So you handle them like babies. Any more questions? Okay, so Alzheimer's disease. Alzheimer's disease. So we're going to look at definition, incidence, types, classifications, etiology or causes and risk factors, pathophysiology, clinical manifestations or signs and symptoms, diagnostic tests, medical surgical management, nursing management, prevention, and complications. So Alzheimer's disease, abbreviated as AD, also referred to as simply Alzheimer's. They're also a chronic, or the three. They are chronic. When they come, you can't cure it. You only manage them. So Parkinson's, Huntington's, and Alzheimer's, they need management. You cannot cure them. So this is also chronic neurodegenerative diseases. So neurodegenerative disease just behaving like the Parkinson. So just behaving like the Parkinson. Parkinson is a neurodegenerative disease as a result of aging. The same thing applies to Alzheimer's disease. So neurodegenerative disease that destroy the memory and other important mental functions. So the area of the brain gets degenerated, and therefore the function of the brain is lost. So in 2015, there were approximately 29.8 million people in the whole world with the disease, AD. And since it's a degenerative changes or degenerative diseases like Parkinson, it affects people with aging around 60, 65 and above. They are more likely to be affected by Alzheimer's disease. We have only 4 to 5%, only 4 to 5% of the cases that are early onset. The rest is late onset. It affects about 6% of people 65 years and older. In 2015, dementia resulted in about 1.9 million deaths. Dementia. This condition was first described by later named after German psychiatrist and pathologist called Alois Alzheimer in 1906. A German psychiatrist and a pathologist, Alois Alzheimer in 1906. He first described the condition, and therefore the condition was named after him, Alzheimer's disease. Types. There are two main types of Alzheimer's disease. Early onset and the late onset. With the early onset, the Alzheimer's disease occurs around the person's 30s to mid-60s. And the percentage is about 10% of all people with Alzheimer's. About 10% of them will happen around the 30s and the 60s, which fall in the category of early onset. 30s and 60s, 10%. And with the 10%, those fall within 30 and 60, some of them is caused by an inherited gene in one of the three genes. So you inherit some, and then the condition progresses. For other cases, research shows that, point out that other genetic components are involved. Researchers are working to promptly identify additional genetic risk variants for early onset. So research is still ongoing to identify other components that can bring about the early onset. But we are now aware that there's an inheritance of one of the 3 genes that leads to the early onset for the 10% of people who get early onset. Some genetic predisposition is related. The late onset, most people with Alzheimer's disease have late onset Alzheimer's disease, and symptoms become apparent in their mid-60s. So the symptoms become more evident, more clear when they get to their mid-60s. So researchers have still not been able to find any specific gene that directly causes the late onset form of the disease. However, one genetic risk factor having one form or allele of the apoprotein E, that the apoprotein E gene on chromosome 19, that's increased the person's risk of getting the disease. So we have the apoallele E, having just one form of it on the chromosome 19 can bring about or increase the risk of you getting the condition. And they are the apoproteins. The ApoE4 is called the risk factor gene because it increases the person's risk of developing the disease, the ApoE4. Just like the Huntington disease, where the chromosome 4, if it gets mutated and the development of the abnormal protein, you get a disease. This one is on the chromosome 19. So having one allele of the chromosome 19, apoproteins, you have the risk of you getting disease as high. So they name it ApoE4, and it increases the person's chance of getting the disease. However, inheriting an ApoE4 allele does not mean that a person will definitely develop it. So it becomes a risk factor. It becomes a risk factor or a predisposing factor. It's not the direct cause. Having the ApoE4 allele does not mean that you definitely have the disease. It rather increases your chance of getting it. So it remains a risk factor. Some people with ApoE4 allele never get the disease. There are some people who have developed or who have inherited the ApoE4. That is the apoprotein allele on chromosome 19. They have it, but they have never developed the condition. And others who develop Alzheimer's disease, Alzheimer's do not even have any ApoE4 allele. So the ApoE4 allele becomes a risk factor. Some people who have the disease do not have the ApoE4 allele. And others who have the ApoE4 alleles may not even have the Alzheimer's. So it's a risk factor. It's not a cause. So the cause of the Alzheimer's disease, we still not know exactly what causes it, except for 1 to 5% of cases where genetic differences have been identified. So it has several competing causes. Hypotheses have been formulated and exist to try to explain the cause of the disease, but we have not yet settled on one. So the genetic the best non-genetic risk factor is the inheritance of the allele E4 or the allele E4, apoprotein E4. When you inherit it, it predisposes you to get the condition. Between 40 and 80% of people with Alzheimer's disease possess at least one of the ApoE4 allele. So this is a research. Between 40 to 80% of people who have possessed ApoE4 allele have the disease. The allele in the TREM, that is TREM2 gene, have been associated with 3 to 5 times higher rates of developing Alzheimer's disease. We have that's the genetic factor, about 40 to 80%. If you have the ApoE4, definitely you have the disease. That is the genetic factor, the genetic hypothesis. What about the cholinergic hypothesis? Cholinergic hypothesis. So the oldest hypothesis on which most currently available drug therapies are based. So this cholinergic hypothesis, the pharmacists formulated their medications based on this hypothesis. Is the cholinergic hypothesis, which proposes that AD is caused by reduced synthesis of the neurotransmitter acetylcholine. Acetylcholine or cholinergic hypothesis. The Alzheimer's proposes that, or formulates, the hypothesis formulates that the cause of the AD, Alzheimer's disease, is the reduced synthesis of the neurotransmitter acetylcholine. The cholinergic hypothesis has not maintained a widespread support, largely because medications intended to treat acetylcholine deficiency have not been very effective. So the cholinergic hypothesis says that it is due to reduced synthesis of acetylcholine at the synaptic cleft, and therefore medications that are supposed to increase or boost the levels of acetylcholine have not been very effective. So even though the hypothesis is there, but the treatment line to boost the acetylcholine has not been effective. So the hypothesis is not well popular, because once you formulated the hypothesis, you should have continued with the medications to see which of the medications can boost the acetylcholine so that you reduce the incidence of Alzheimer's disease. But you just formulated the hypothesis that there's reduced synthesis of acetylcholine and therefore the disease. So what are the medications to boost the acetylcholine to reduce the disease occurrence? Then we have the amyloid hypothesis. Amyloid hypothesis. In 1991, the amyloid hypothesis postulated that extracellular amyloid beta deposits are the fundamental cause of the disease. So we have the amyloid beta deposits. They are the fundamental cause of the Alzheimer's disease. Support for this postulate comes from the location of the gene for the amyloid precursor protein, APP. Amyloid precursor protein on chromosome 21. So together with the fact that people with trisomy 21 with the Darwin syndrome who have an extra gene copy almost universally exhibit at least the earlier symptoms of Alzheimer's disease by 40 years of age. So the diseases that affect the trisomy 21, Darwin syndrome, also have chances of developing Alzheimer's disease by age 40 and above. So here we have the amyloid beta deposits. They are the fundamental cause of the disease. So the amyloid precursor protein, APP, on chromosome 21. And the fact that people with trisomy 21 develop the disease around age 40 confirms the postulate or the hypothesis. Then we have the Osaka mutation hypothesis. Osaka mutation hypothesis. A Japanese pedigree of familial Alzheimer's disease was found to be associated with a deletion mutation of codon 693 of the amyloid precursor protein, the APP. And this mutation and its association with Alzheimer's disease was first reported in 2008. This mutation is known as the Osaka mutation. Osaka mutation. So here there is a deletion mutation of codon 693 of the APP. And this mutation and its associated with Alzheimer's disease was first reported in 2008. And it was named after the Japanese pedigree Osaka mutation. So he identified the deletion or the mutation of the codon 693 of the APP protein. So they named him as Osaka mutation as the cause of the Alzheimer's disease. Then we have the tau hypothesis. The tau hypothesis. So the tau hypothesis proposes that there's a tau protein abnormalities that initiate the disease cascade. A tau protein abnormality. In this model, hyperphosphorated tau. So there's excessive production of tau protein. Hyperphosphorated tau protein begins to pair with other traces of tau. So there's too much production of tau and they pair up like strands. Eventually they form neurofibrillary tangles inside the nerve cell bodies. When this occurs, the microtubules degenerate, destroying the structure of the cell's cytoskeleton, which collapses the neuron transport system. So the neurofibrillary tangles find its way inside the nerve cell and they end up destroying the nerves transport systems. So impulse transmission becomes a problem in the presence of the neurofibrillary tangles, the tau proteins or tau hypothesis. When they form the strands like thread, they enter the nerve cell bodies and they cause degeneration of the microtubules. And once they destroy the structure of the cell cytoskeleton, they collapse the neuron transport system. So impulse transmission is heavily impeded. And this may result first in more functions in biochemical communication between neurons and later in the death of the cell. So once you see the tau proteins or the neurofibrillary tau tangles, these tangles affect the movement of information from one nerve cell to another nerve cell. So there's impeding or there's obstruction. There's impediments to the flow of information. Because the transport system that's supposed to relay information from one side to the other is destroyed by the presence of the tau neurofibrillary tangles. Then we have the other hypothesis. An inflammatory hypothesis is that Alzheimer's disease is caused by or is called due to self-perpetuating progressive inflammations in the brain, adding up in neurodegeneration. So inflammations, infections that enter the brain cells and you don't put or treat, they end up causing degeneration of the neurons. That is inflammation and other hypotheses. A neurovascular hypothesis has been proposed, which says that poor function of the blood-brain barrier may also be involved, because if the blood-brain barrier is poorly functioning, it allows certain molecules to enter the brain while they are not supposed to enter. And once they enter, they impede the functions of the nerve cells in the brain. So inflammations and the permeability of the BBB also destroy the brain nerves, and this can also cause the disease, Alzheimer's disease, to occur. So we have the cellular homeostasis of biometals, such as ionic copper, iron, and zinc is disrupted in Alzheimer's disease. Though it remains unclear whether this is produced by or caused the changes in proteins, these ions affect and are affected by tau, the APP, and then the APO ions. And their dysregulation may cause oxidative stress. Once you hear oxidative stress, then it may contribute to the pathology and other cancer development. The mutations can result from oxidative stress. So the ions we mentioned, the copper, the iron, the zinc, their functions are heavily affected by the presence of the tau proteins, the APP, and then the APO alleles. When they are present, they cause a poor regulation and lead to oxidative stress, and that contributes to the condition Alzheimer's disease. So these metals are not able to function properly when we have the tau proteins, the APP, and then the APO alleles. When they are there, they cause the malfunctioning of these metallic ions, copper, and they may contribute to the disease. So risk factors, we have smoking, it's a significant risk factor for Alzheimer's disease. Systemic markers of the innate immune system are risk factors for late onset of the disease. Tentative evidence that exposure to air pollution may be a contributory factor to the development of the disease. Depression, head injury, hypertension, all are risk factors. They are all risk factors. So avoid pollution, avoid depression, head injury, hypertension. Smoke should be avoided. We will end at the pathophysiology and continue from pathophysiology next week when we meet, and consider other nervous conditions, like multiple sclerosis, epilepsy, and other conditions. Any question, because we have just a minute to close. Any questions so far? Okay, so in the absence of any further questions, we bring the lecture to a close. It's 4 o'clock. We will continue from nervous system when we meet next week. Have a wonderful weekend. May the good Lord be with you till we meet again. Enjoy your weekends. Bye-bye.